Well, hello, everyone. Welcome to one of many educational webinars that SAMBA will be hosting this upcoming year. Today, we'll be reviewing what medical directors should know about infection and prevention at ASCs. This will be led by Dr. Leo Rodriguez. I am Dr. Catherine Tobin. I'm an associate professor at the Medical University of South Carolina in Charleston. I'm also chair of the Education Committee for SAMBA. I will be moderating this webinar. For those of you that are not members of SAMBA, please consider joining the society, as it offers many benefits to members. You can visit our website and see the benefits. In addition, you can listen to previous webinars online. A few quick housekeeping notes before we get started. In the upper right-hand side of your computer screen, you will see a control panel. Please note this webinar is in listen-only mode. Submit your questions in the question box at any point during the presentation, and I'll be reviewing these during the presentation. At the end, we'll have time for a Q&A presentation where I'll read your questions out loud. I'd like to now introduce Dr. Leo Rodriguez. He's a native of Venezuela, and he is medical director of a surgery center in Aventura, Florida, where he's done that position since 2008. Dr. Rodriguez is also president-elect of SAMBA. He's the vice president of the Florida Society for Anesthesiologists and a member of the ASA Committee on Ambulatory Surgery Care and CPOM and other committees. Let's now welcome Dr. Leo Rodriguez.
Well, hello, everyone. I'm happy that you joined us for this presentation. It's the presentation. A lot of the material that I have is known by a significant number of you, but unfortunately is ignored by a significant amount of anesthesiologists. And my goal in this presentation is to see infection control from like a chief medical officer point of view. And we're gonna have, sorry, my presentation, okay. So the learning objectives of the presentation are, first, we're going to define what healthcare-associated infections are and why should we care. Then we're going to review a few cases of infections that originated in the healthcare system. We're going to see the gaps that occurred in those infections, and then we're going to address those gaps to prevent other infections from occurring in our environment. I have two disclosures, but my disclosures have no influence on any part of my presentation. Ambulatory surgery at the moment in the United States, we have approximately 5,500 certified surgery centers by CMS. In 2015, approximately 3.4 million surgeries are performed in Medicare patients in the United States. And about $4.1 billion from the Medicare budget is spent in ambulatory surgery. So the government, obviously, based on these numbers, has a significant focus on prevention and infections because they want to decrease the expenses in complications from any kind of surgery. This graph comes from the American Hospital Association, and what it shows is the shift that has occurred from inpatient procedures to outpatient procedures. So as you can see, between 1994 and 2014, the number of surgeries have increased to above 63% in the United States that are being performed in outpatient surgery, not necessarily ambulatory surgery centers, but in hospital outpatient departments, non-operating room environments, and ambulatory surgery centers. And at the moment, it's estimated that approximately 30 million surgeries are being performed in the United States in outpatient settings, including the office-based settings. So what are healthcare-associated infections? So a healthcare-associated infection is an infection that is acquired while the patient is receiving care for another condition. Infections in ambulatory surgery settings are relatively infrequent in comparison to a hospital setting, but when an infection does occur, it causes a lot of cost for the healthcare system. It is estimated that right now about $30 billion a year is spent on healthcare associated infections and the management of patients that suffer this type of infection. And the trends are that if we continue the way we are, they could increase because now we're developing multi-drug resistant organisms. One of them is a VRE, which we know that is transmitted by person-to-person contact. So if you have a patient that comes to a facility, the patient's colonized with VRE, and the healthcare providers don't take care of the things they have to do, then the next patient could suffer a VRE infection. So now we're going to review data related to ambulatory surgery. The most significant article was published in 2014 in JAMA. And in this article, they found that approximately 3.09 patients per 1,000 surgical cases done in ambulatory surgery centers have infections reported in the first 14 days. And within the first 30 days, 4.84 out of 1,000. So this is a significant number, based on the numbers that I mentioned before, that approximately 30 million surgeries are being performed. So it has it could have a significant financial impact on ambulatory surgery. 63% of patients receive care within the first 14 days after the surgery when they acquire a surgical site infection, and about 93% of that care is performed in an inpatient setting. So as you can see, this is what adds cost from the ambulatory surgery point of view. And I'm going to present some information about lapses in infection control that have happened in ambulatory surgery. And then we're going to talk about quality improvement projects that we can do to decrease the infections. Traditionally, anesthesiologists add lidocaine to propofol because we want to decrease pain on injection. And as you know, when you draw drugs from a vial, it becomes a compound if unused. This is by USP 797. So you should use that drug within an hour, or you should waste it. There is a literature that demonstrates that local anesthetics actually have bacteriostatic activity. So some people have drawn lidocaine and put it inside a vial of propofol. This is a mixture that is approved by the FDA. You can actually mix 20 milligrams in 200 milligrams of propofol, and that's a FDA approved combination to be used to prevent infection, to prevent pain on injection. However, the lidocaine has not stopped bacteria from reproducing in the propofol emulsion, because as we know, it's a very lipid-rich environment, and it's bacteria love propofol. There is an author that I mentioned there, Weber and colleagues, and they reviewed some cases when propofol was first introduced to the market. And what they found was that some anesthesiologists and a facility would have large vials of propofol with 500 milligrams of propofol. And they would spike the vial, and then they would use the same vial through a period of 8 to 12 hours. And it's very interesting to read this article. I mean, there were instances in which propofol was drawn into syringes and was not used. They would draw like 8 syringes of propofol, and they were not all used after being withdrawn. And this anesthesiologist would go to his partners and say, hey, let me give you the syringes since you're doing some cases. At other times, they would take that propofol syringe to another hospital because it was expensive at the time. It was a trademarked medication. And they would use it in another hospital. And multiple patients in multi-sites developed infections. And when they did the epidemiologic review of this phenomenon, they found that it was all originated from an anesthesiologist that had this practice at an ASC. In 1995, there was a publication in New England Journal of Medicine, and they were talking about infections that were occurring after the introduction of propofol in the marketplace in the United States. So they found that between 1989 and 1990, multiple patients were having bloodstream infections, surgical site infections. And traditionally, we think that infections at the surgical site or bloodstream are related to the actual surgical procedure. But the CDC got their attention with this, and they did surveillance between 1989 and 1994, and they found that in 20 states, approximately 155 patients reported to have fever or infection or sepsis after being given propofol. And 4 patients died. And when the CDC investigated, they traced the infections to contaminated propofol. In the year 1997, there's also documentation of transmission of hepatitis C virus during colonoscopy. In this publication, this was in Europe, in France specifically, and multiple patients were infected with hepatitis C, and then they were studying to see what was happening, and they have unsafe injection practices at the time. So again, because propofol was so expensive when it was first introduced, they were sharing syringes between patients, or they were using the same syringe on one patient. And I'm going to talk about that later to show how this can cause infections. And then accidentally they would use that vial on another patient, and that would cause the transmission from one patient to the other. They had the thought at the time that because they had put a special valve in the IV tubing, that this would prevent blood from backing up into the IV tubing, and they thought that it was safe, and it was actually making it unsafe for the other patients because they demonstrated that there was actual backup of blood into the tubing and the syringes, and the anesthesia was actually causing the transmission of the infections. A famous case report that was in Morbidity and Mortality Weekly by the CDC in 2008 reported the famous 2007 unsafe injection practices at an endoscopy center in Nevada, and multiple patients were infected with the hepatitis C virus. I have 2 references there. The one on the left, it's also from Europe. And what they found was that patients were going to have ambulatory surgery procedures, and they had actually they studied these patients to investigate what was happening. And for instance, they had a patient that was a 35-year-old young female who had never been exposed to hepatitis C before the procedure, was not an IV drug user, did not have contact with any person that had hepatitis C. The anesthesiologist, the nurses, and the surgeon that took care of her did not have hepatitis C. The patient never received a blood transfusion or anything else, and the patient developed hepatitis C infection. And she was just getting a ganglion cyst removed from her wrist. And then, they did more surveillance, and they found that about 1,200 patients in the surgery center that does about 5,000 to 6,000 cases a year were exposed to hepatitis C because of their unsafe practices. On the right side, there is a recent publication from Anesthesiology in which they demonstrated that when we have multi-dose vials inside patient care areas where there is a GI endoscopy suite or an operating room, there is aerosolization of bacteria and virus in the air, and the top of the vial can get contaminated. And they demonstrated that by cleaning the vial top with alcohol and allowing it to dry does not protect the vial from hepatitis C infection. And they actually pierced the vial top after following this cleaning with a new needle and a new syringe. and they drew the medication and they used the medication, and then they cultured this liquid inside the vial, and they demonstrated that the actual hepatitis C virus was viable for multiple days after that single piercing of a contaminated vial top. So the recommendation that came out of this article was that we should not have ever multi-dose vials in patient care areas, because they demonstrated the risk of hepatitis C infection because of that practice. So when we analyze all these things from the epidemiology point of view, we know that we have a host, which is the patient, we have the infectious agents, and then we have an environment. And this environment includes the anesthesia work environment, includes the anesthesiologist or the allied health provider who's taking care of the patient, the surgeon, the nurses, and various factors. So we're going to go through each one of them. In regards to the host, the patient, it has been demonstrated that when patients are under general anesthesia with a volatile agent, in a time related fashion, they demonstrate that there is a reduction in the migration of neutrophils. Phagocytosis is affected, and this has happened with both sevoflurane and isoflurane. So there is immunocompromise with volatile agents. They have not been able to demonstrate the same with IV agents. In regards to the environment, we have the operating room and the stretchers and the pre-op and the PACU area, but what we call the anesthesia work environment is the anesthesia machine, the anesthesia cart, the anesthesia tools that we use, laryngoscopes, endotracheal tubes, gels, syringes, vials, IV catheters. And then we also talk about direct and indirect contamination. Direct is when, for instance, our hands are soiled and we touch a patient, we're doing direct contamination. Indirect is we contaminate the IV tubing, and then we inject things through that IV tubing, and that goes inside the patient. So this is a simulation environment. This study was done by Dr. Birnbach in the University of Miami, and he's the head of quality for the hospital system. And this is the Anesthesia Analgesia 2015. So what he did was he put a small amount of a contrast dye in the mouth of the mannequin, and then he went outside and he asked residents of the University of Miami, CA2s and CA3s, to go inside the operating room and put this mannequin to sleep for general anesthesia. And then once they finish whatever they were going to do and put the patient on a ventilator, to leave the room. Once they left the room, he went inside with a lamp to find where was this dye present. And you can see the image on the right side, that a small amount of dye in the mouth of the mannequin, with the mouth opening maneuver that we do, the airway management, contaminated the hands of the resident, and then to adjust the face of the mannequin, it contaminated the face. It contaminated the injection port of the IV tubing where it was going to be injected. And then on the left side, you have a picture of an operating room, and where you see the red stars, those are the areas where they found the dye in the operating room. And this is like a 3 to 5 minute period that the resident was interacting with this mannequin. And that's how contamination gets spread. There's been publications in anesthesia analgesia also that demonstrate that laryngoscope handles and the laryngoscope itself can easily become contaminated. And remember a few years ago, whenever we're doing cases, we would use a laryngoscope, and then at the end of the case, we would come out and wash the laryngoscope, and people would apply chlorhexidine or betadine and would brush the scope, and then they will go back inside. But actually, they've demonstrated that there's bacteria, and out of this is recommended that we follow the manufacturer's recommendations, which requires sterilization of the handle. So this means that for every case or every room, you have to have at least 3 laryngoscopes ready, because you're going to use one, and then that one's going to get sterilized, and it takes a significant amount of time to go through the whole process to do the procedure. Some people have elected to use disposable laryngoscopes to avoid going through all this process. Another thing that we don't think about is um, the circuit. So when the patient breathes in and out, there is possible contamination coming from the anesthesia machine to the patient, or from the patient to the anesthesia machine. So this is an article that was published also in Anesthesia and Analgesia, but it was in 1991, and they use a brand name there. There are several brands that can be used, um, um, but this filters, they prevent anything that is more than 4 microns in size to go through the filter. So if you have a patient that has a respiratory infection, or is colonized with certain bacteria, and you ventilate the patient, the filter will prevent the anesthesia machine from getting contaminated, or vice versa. If the anesthesia machine is contaminated, the application of these filters will prevent the colonization of the patient through the airway. Some people believe that soda lime or the inhaled anesthetics are prevent bacterial, and they're actually ineffective doing so. This is the way we contaminate syringe, the inside of a syringe. So as you can see, the right hand is on the plunger of this syringe, and they're withdrawing medication into the syringe. And then when they inject, that area that is in touch with the index finger of this figure is going to be inside the syringe. So when they reuse that same syringe in another vial, the contents of the syringe are going to be contaminated with the bacteria of the finger of that hand in the figure. So that's why we should never reuse a syringe, even on the same patient, even with the same vial. We should just draw, use it, and then toss it. This is another interesting study that was published by the University of Florida group. The lead author is Dr. Devon Cole. He's a Floridian. I know him personally. And this study was very interesting because what they did is, in an ambulatory surgery center, they would inject propofol into patients either through injection ports or through stopcocks. And then when the patient was discharged, they would cut the injection port, or they would separate the stopcock. They would put it in a sterile container at room air for about 6 hours, and then they will culture the contents of the stopcock or that injection port, and they were able to produce infection. The bacteria grew, whether they were using propofol more frequently or not using propofol, but it still happened. One of the conclusions that they came out of this the study was, they said that if people are adhering to the SCIP program and they're injecting antibiotics on a timely basis, why haven't infections decreased significantly? There has to be another source. And the other thing that they said is, they proposed that perhaps whenever we use propofol in the operating room, when the patient leaves the operating room, or leaves the PACU to go to a floor in case they're being hospitalized, that perhaps the IV should be removed and a new IV should be inserted. And because probably all the tubing was already contaminated with the bacteria, though, because of the propofol injection. Hand hygiene, and this is a bad one. So this author is a Japanese author that has made a career out of infection control and anesthesia. And one of the things that he points out in multiple studies is that anesthesiologists tend to not adhere to hand hygiene as they should do. And they cite comments from anesthesiologists. They say, well, when I'm doing a patient that's infected, then a high risk patient, then I do to take good care of my hands. I wash my hands frequently. But if I'm doing a low risk patients, then I don't. And some people don't use gloves. So let alone they don't wash their hands, but they don't use gloves, so these are not good practices. Fukada, the author, he has done cultures on patient on anesthesia providers before, during, and after the procedure, and he demonstrates that bacteria, the flora in our hands changes through the case and after the case, and also the patient's flora changes because of bacteria that we have in ourselves and grows on the patient's skin. This was published in June 2016 in the APSF newsletter, and basically what they mentioned was that they did surveillance of anesthesia providers, and they found that anesthesia providers have significant lapses in hand washing and antibiotic dosing, that they tend to have low compliance with their high hygiene recommendations. The hand contamination serves as a significant source of anesthesia work environment contamination and stopcock contamination, and that they estimate that in any single case, there are about 60 opportunities for hand hygiene. And in general, people do hand hygiene once per hour during a procedure. They recommended the use of the alcohol dispensers near the anesthesia workstation and near the entrance of operating rooms, so that people have a higher opportunity to do hand hygiene. As you know, ideally you want to wash your hands, but secondary, using alcohol solution is also something that you can do during the case. So now, in review, we have from the epidemiology point of view, we have a patient who's immunocompromised, who may have poor perfusion on their skin because they're vasoconstricted, because they're hypovolemic, or they're hypothermic, or they're hyperglycemic, and it's a culture-rich environment. We have infectious agents that are present, and we have to administer antibiotics at the proper time, and the proper antibiotic and proper interval. And we have an oral environment who could be cold or could not be disinfected properly, and that could be contaminating the patients. And that's why patients are getting contaminated. And as I presented before, a lot of people doubt when we present this data, but I've demonstrated at the beginning of the presentation that we actually have contamination of our hands, that we are contaminating the patient in the anesthesia machine, and that could cause VRE infection in other patients, or such, or Staph aureus and VRE, methicillin-resistant staph, and with unsafe injection practices, we can transmit viruses or bacteria. So this is published in JAMA in 2010. And what they were looking at, so this is CMS, and they picked 5 states. And in those states, they picked a volume of 68 ambulatory surgery centers. And they went to do CMS inspection of the facilities, and they focused on 5 things: hand hygiene, safe injection practices, equipment reprocessing, environmental cleaning, and the handling of blood glucose monitors. And they did not interfere. What they found was that 46 out of 68 ASCs, that's about 67%, had at least 1 lapse in infection control, and 12 of 68 had at least 3 lapses in infection control. And because of this, the regulators came up with a national action plan to prevent healthcare-associated infections. And one of the chapters is the chapter on anesthesia and in ambulatory surgery centers. And they said that they want us to be more proactive in prevention of healthcare-associated infections. They want us to have more oversight and expand improvements in monitoring. And they also want us to develop meaningful ways that we can do healthcare-associated infection surveillance and reporting. We are supposed to do the one needle, one syringe, and only one time campaign. There is a link if you want to follow it. We have to follow the World Health Organization recommendations on hand hygiene. That's before patient contact, before aseptic tasks, after the patient contact or after body fluid exposure, and then after leaving the room to prevent propagation of bacteria and viruses. A recommendation that came out of Dr. Birnbach's article that I presented earlier in the simulation is that people should wear two gloves. The person that's managing the airway of a patient should wear two pairs of gloves to prevent contamination of the anesthesia work environment. So what you would do is you pre-oxygenate the patient, and then the anesthesiologist or some injects the medications into the patient. You do your airway maneuver, you intubate the patient, and then before you transition to connecting the circuit and turning on the pop-off valve and bagging the patient, that then you should remove the top glove off and keep the lower glove off, and that way you can diminish the contamination of the anesthesia work environment. From the ASC Quality Collaboration Project, so this is the Association of Surgery Centers. They participate with CMS in the development of quality measures for ambulatory surgery, just like we have our MIPS or MACRA program for physicians. They have their program for the facility, and 5 of those things that are in this list, so these are the actual list of measures for this year. The ones in red have something to do with infection control. So patient falls because they can damage the skin. When they fall, a patient burns because obviously it becomes an open wound. The prophylactic use of IV antibiotics on a timely fashion, appropriate surgical the surgical site hair removal, and normothermia, because they want to make sure that the patient's normothermic to prevent vasoconstriction and shivering and all those things. The Center for Disease Control came out with recommendations to prevent surgical site infections. And one of the things that they mentioned is the antibiotic prophylaxis should be given on a timely fashion at the right dose and with enough time before incision so that you can get blood levels at the tissue, blood and tissue levels before you make the injury to the patient. Control glycemia, maintain normothermia, maintain oxygenation, and then be careful with prosthetic total joints. It is said that in the near future, between the year 2020 to 2050, we're going to be doing about 3.8 million total joints in the United States per year. And they calculate that infections in those joints could increase to up to 6.5% if we don't follow safe infection prevention practices. And that's where they're very concerned. This is from SHEA. They publish recommendations for infection prevention. So you should look for this document. And this document is a partial view of a table. They basically tell you which antibiotic, the appropriate dose based on weight, and then they give you the pediatric dose, and then which interval you should redose the antibiotic. So the most typical is NSAF, cefazolin. And if a patient weighs less than 60 kilos, it's 1 gram. Between 60 and 120 kilos, 2 grams. And then 3 grams is more than 120 kilos. And then after 4 hours, you should repeat the dose, and so on. This is the hour in which the dose should be repeated, and you're going to repeat half the dose. So if you gave 2 grams, you're going to give 1 gram. If you gave 1 gram at the beginning, you're going to give half a gram to maintain adequate blood levels of the antibiotic during the procedure, or if you have significant blood loss. The same organization, SHEA, published an infection prevention guidelines article that is very extensive of how to prevent infection of the operating room work area, and it's dedicated to anesthesiologists and allied health providers that perform anesthesia. And then lastly, CMS wants us to do more surveillance on our facilities, and we actually, each facility has an infection control nurse that does surveillance on hand washing and scope cleaning, reprocessing, and all those things. But we never have anybody focusing on anesthesia. And there is something called the Hawthorne effect. The Hawthorne effect means that whenever you're doing surveillance on somebody, whenever you're observing somebody, their performance improves. So this is a way by following a checklist and letting people know that on a timely basis you're gonna do a surveillance of them. They improve the way they do things, and this is not to be used as a punitive measure. It should be used as a preventive and education measure so that you can do surveillance on the way your staff manages patients, and then make them aware of what things are doing wrong and what is recommended by SHEA, the CDC, and other organizations. And I created this checklist for anesthesia providers that covers hand washing, safe injection practices, the clean anesthesia work environment, the airway management, and the scrub attire. And this should be used periodically at your facility. A lot of we're in SAMBA, we're putting a lot of effort on education of physician anesthesiologists to become medical directors, to become better medical directors. And we're working right now on creating, with the Association of the Ambulatory Surgery Center Association, ASCA, a certification program in which we can combine the medical knowledge of SAMBA and the business knowledge of ASCA together to improve the quality of medical directors in the future. The first effort that we're doing is during the SAMBA meeting in May 2020, we're going to have a combined meeting of both societies. So you're going to have SAMBA and ASCA, and we're actually going to have combined sessions where we have faculty from ASCA and faculty from SAMBA discussing the same issues from a different perspective. And we think that this is going to improve the way anesthesiologists perform in ambulatory surgery centers and will make us better medical directors. This is the date and the location of this meeting. And then I'm going to stop talking for now, and I'm going to wait for questions to come in.
Well, thank you, Dr. Rodriguez. That was a very informative presentation. I kind of thought of some pearls while you were talking, and then I also had a question. One of them was that study you mentioned from anesthesiology in 2019 about the vial just sitting on the back of my anesthesia cart and being contaminated just by sitting there. Is that by the air and Hep C? And so, not using the same vial and the next, having it, even if it was a multi-dose vial. Can you explain that again?
Yes. So I didn't present it in this presentation, but basically they have done studies in which when a surgery is happening or a colonoscopy is happening, they've actually brought culture containers into the room, and they've done cultures of the air from right on top of the patient, and then they go a distance, like they go 1 foot, 2 feet, 3 feet, 4 feet, 5 feet away, and they can actually demonstrate that there is bacteria and viruses also in the air that come from the patient. So they culture the patient, and then they culture that air, and there's correlation in the genome of those of the two bacteria or viruses. Another thing is that remember that we're constantly touching the patient and going back to our cards because we're redosing and things like that. So accidentally we can contaminate a vial. So for instance, in my facility, we never have multi-dose vials in the patient care areas. What we do is we tell people that if we do have a multi-dose vial, that we're going to use it for that single patient, and then at the end of the procedure, we're going to toss the vial as if it was a single-use vial. And this is a recommendation from SHEA and from the pharmacist to do this, because we should never have multi-dose vial in patient care areas because they become contaminated, and then that can go inside the liquid, and then when we inject it into the patient, we can uh, contaminate the patient. Was that clear enough?
Yes, it is. It is. And I think that campaign you mentioned, the one vial, one medication, one patient, because I feel like I have seen people say inducing anesthesia, pushing propofol for an LMA placement, and then they realize they need more propofol and they use the same syringe because they think, oh, it was just used on this patient, but really they definitely need a new syringe. And so I think that's a good pearl to take from this lecture.
Yeah, thank you. Yeah, there's people don't understand that they're actually contaminating the inside of the syringe when they withdraw and then they inject. When they withdraw again, that drug inside the syringe is going to be contaminated with whatever bacteria you have in your hands. So that's why people should always wash their hands before starting a case. They should always put gloves on and then follow the safe injection practices, cleaning the vials. The people don't know that when you pop a vial, the first thing you have to do is clean the top of the vial and wait for that alcohol to dry before you actually pierce. Unfortunately, we've demonstrated that hepatitis C virus does not die when we do that, but we're preventing bacterial contamination of the contents of the vial when we do so.
Yes. We do have a question that they wanted to know, do you have any sample policies that anesthesia chiefs can use to encourage proper infection control procedures? You did mention the Hawthorne effect and sort of that checklist. Do you have anything,
Yeah,
a way to answer that question?
yeah. So the every ambulatory surgery center should have a policy and procedure manual, and we have one for anesthesia, and then we have one that's for the entire facility. So the one for the entire facility says that we're going to do surveillance on the providers on a regular basis, and it's just generic because we do this on gastroenterologists. We make sure that they're washing their hands before and after a colonoscopy, that they're applying a hand sanitizer before they go back and talk to a patient after, in the recovery room to give them results. And we're constantly doing that surveillance. So we're doing the same surveillance on the anesthesia providers. And I actually have a nurse, the infection control nurse, and when she does her surveillance, she does this hand hygiene, anesthesia workstation evaluation, airway management evaluation, because I train her to do this and she's the official infection control nurse. So what I'm adhering to is the policy of the facility and following AAAHC guidelines.
Thank you. I also took a pearl from this lecture that just wanted to hear you say it again, that if you draw up propofol and add lidocaine in the syringe, that is only good for 1 hour. Is that correct?
That is correct. So the USP 797 says that whenever you withdraw a drug and you're not in ISO 5 conditions, which is when you're inside the bubble, the sterile bubble, that drug becomes a compound. And the US 797, the rule says that you must use that within an hour. There has been some changes that are going to be coming up for that, in so that as of now, you have to waste the drug within an hour after you put it in a syringe. But there's an update that's going to be published in December this year, and it's going to be active next year. It says that you have to use it by the end of the case, but you have to have used the vial within the first hour, and if not, you do have to waste it. So you are correct in what you said. And
Okay.
they also have rules for like IV tubing. So whenever you spike an IV bag with saline, you also have to put a label with a time, and then you have to use it within an hour, and then you have to waste it if you don't. If you attach it to a patient, it's good for up to 12 hours, and after 12 hours, you should change that system.
Gotcha. Another question I have is related to ANSEP or ceflazoline. You mentioned giving it time to work before incision. How long do you think that is in a patient with normal, kidney, hepatic, normal function? How many
Yeah.
minutes?
So when you look at the skip protocol, and I criticize it because, they just say that you have to give it before incision. So a lot of people, they wait till they go into the operating room and they inject it with a syringe. They bolus it right before incision, and that's not acceptable. So as far as you can get to an hour from the moment of incision. In general, what I try to do is do it about half an hour before incision. And, since we're always there at the facility, we know how much time each surgeon takes before they actually make incision because we look at them constantly and we learn to time that timing. We have surgeons that we put the patient to sleep and they put the tourniquet immediately, they inflate the tourniquet, and then they go out, they wash their hands, and they come in and they get started. And then you have other surgeons that they go out, they wash their hands, and then they come in, and then they put the tourniquet sterilely. And so that surgeon is going to take more than 30 minutes. So ideally, and there's a study published in the Swiss Anesthesia Journal, and they demonstrated that the farther you go from the incision time, up to an hour, you have better concentration at the tissue level than if you give it right away. I'm sorry I didn't put the reference here, but I have the reference in my computer. So 30 minutes should be ideal. An hour also ideal. And remember, vancomycin is 2 hours. So when you think that if you have an incision at 8:30, if you think you're going to do incision at 8:30, you should start the vancomycin infusion 2 hours before. So when you're admitting the patient, you put the IV, you start the vancomycin infusion over an hour, so that as long as you're within a 2 hour period to start, you're fine with vancomycin.
Okay. Another question, at your ASCs, first of all, do you do patients that have known VRE or known MRSA? Should you be changing scrubs after you take care of them? I know a lot of hospitals just use disposable gowns.
Yeah, so that's a recommendation. So the MRSA is less worrisome because unfortunately MRSA is everywhere. We have in Fort Lauderdale, Florida. If you go to the beach there in the sand, they have actually done cultures of the sand in Fort Lauderdale, and MRSA grows there. We do all these infection control practices, and then you go to the elevator and you culture the elevator, and you're gonna find MRSA there. In the infectious disease community, they basically say that everybody's contaminated. Everybody has a grandma that's in a nursing home. Now, VRE is more worrisome. And in my facility, we do patients that are contaminated with VRE. But what we do is we do that patient as the last patient of the day, and everybody takes precautions that they wear gowns and boots and gloves, and they wear a face shield, and then it's the last patient of the day. So when they finish that case of the day, the patient is recovered in the same patient care area where they were in the room, and then they're discharged from that room. And then that room is terminally cleaned before you. So they apply bleach to everywhere to decontaminate this room so it can be used the next day.
Okay, yeah, that's a good concept. We have another question that comes from the audience, and it says, what do we do about when we have a bigger syringe of propofol and you've only used part of the drug? How long can we wait with the medication in the syringe to redose in the same patient? And is it the same 1 hour as an open vial? So in other words, I think what they're saying is if you had 20 cc's of propofol and you only use 10, how long till if you can use the rest, if I understand the question correctly?
So if you follow the rules to the dot, the rules say that you have to use it within an hour. Like I said, the USP 797 is being updated right now, and in December, they say that you can wait till the end of the case. Now, propofol is a very tricky drug because, if you read the manufacturer's package, it says that you can wait 6 hours and you're fine. But personally, after an hour, I waste propofol, and I just document that I wasted the propofol, and I pull out another vial, and when I need to use it, then I pop the vial, I clean with alcohol, and then I use it, because propofol is a very culture-rich drug.
I see. Another pearl I took from this was that slide that you showed in the simulation center with the red stars and all that contamination that just came from someone coming in to quickly do an intubation and then leave, how everything was contaminated. That was That's a powerful image.
Yes. So,
Going back to
I think,
double glove, double glove.
yes, I think that everybody should read that edition of Anesthesia and Analgesia 2015, and there were like 10 articles in that edition that talk about infection control and double glove thing, and we actually do this on my facility.
Yeah. I just got another question in that's very something good to think about is contamination of our charting devices, our computers, and even our cell phones that we carry everywhere.
Yeah, that is correct. So whenever we do a case and we have our iPhones with us, and we should be, as soon as you finish the case, you should clean the iPhone with alcohol or any other cleaning solution uh, to decontaminate, because that's very common. So, I also do that with, we use electronic health record. We use iPads in my facility. So I always recommend that everybody cleans the iPad between cases before starting the next case. And I do mostly pre-ops or supervise people medically direct. So I tend not to bring my iPad into the patient care area, into the OR or the GI room. I'm just there for induction, and I leave my iPad outside to, decrease the chances of decontamination. But our devices in our facility are covered with a device that protects it physically from breaking, but also allows us to use a very strong cleaning solution and not damage the device.
Yeah. Something at my hospital, I'd like to just add anecdotally that we realized that we weren't cleaning or the little, kind of like the little clamps we were using to papoose patients, especially for ENT procedures, quick turnovers. And we were, doing our papoose, and then we'd hang them back on our IV pole, and we realized they weren't getting washed between cases because they were just hanging on the pole. So now we have a policy where at the end of the case, when we take the towel clamps off, we make sure to give them to a nurse to clean between the cases.
Exactly. So, in my facility, the CRNAs, when they do the cases, or the anesthesia assistants, when they do the cases, they take the patient out of the room to the PACU, and then they come back to the procedure room or the operating room, and they clean all the cables, they clean the monitor of the anesthesia, they clean the anesthesia machine, the anesthesia cart. They clean everything, and they do the same thing with the poles. That would be the scrub tech usually cleans the IV poles and the lights and all those things. Decontaminating the room before the next procedure. Very important.
All right. And I have another comment from the audience that just wants to remind us that mixing propofol and lidocaine is strongly discouraged. First, because the lipid emulsion is not compatible with lidocaine, thereby altering pharmacokinetics. Second, there have been case reports of lipid separating causes fat embolism on subsequent injection.
Yes,
So
that is correct. That is correct. But you can also check. There's a FDA um, message that came out probably about 5 years ago, and they said that up to 20 milligrams, so that means 2 cc's of 1% lidocaine or 1 cc of 2% lidocaine, is approved by the FDA. If you use any more volume than that, then you do run the chance into causing the separation and causing lipid embolism. So you are correct, but the FDA allows, it's actually FDA approved to do 20 milligrams and 200 milligrams.
Okay. This has been a very informative webinar. I feel like I've learned a lot from it. So thank you for your time. Does anyone else have any other questions they'd like to put in here at the last minute?
And again, a lot of people, when I give this presentation, they're dismissive, and they say, "Oh, this never happens." What is really the importance of this? And as I show through history, we have caused infections in patients, bacterial. We have caused hepatitis C infections, HIV infections unfortunately, from drug diversion, and medication safety and infection control are very closely linked in anesthesiology, and we should always follow all these guidelines. And we should always think that the patient that we're taking care of could be our mother or a grandmother, knowing that it's somebody else's mother and grandmother. And we should always try to be the best we can be.
Wonderful. Well, thank you all for participating in this webinar. Shortly after the webinar, participants y'all are going to receive an email from SAMBA that includes a link to an evaluation. So please take a minute to provide your feedback. The recording of the webinar, along with any handouts discussed, will be posted on the SAMBA's website in the future. And we hope you join us for upcoming webinars. We will send out notifications. We already have one scheduled really for October, November, December, and I even scheduled a January one today. So we're going to keep this up and running. All right. Thank you, everyone. Bye.
Thank you, everyone. I'm waiting for that. The recording has been finished.
Yes, I'm doing the same.